Welcome to Concerned Citizens Presents. Concerned Citizens of Laguna Woods is an organization dedicated to peace, economic and social justice, good government, and a clean environment. Every month, we invite an expert to enlighten us on a topic related to our mission. Because Village TV videotapes these presentations, we can share that expertise with a larger audience. We hope you enjoy today's broadcast.
Now, by way of introduction, I want to summarize an article that appeared in The Guardian on June 1st. The Association of American Medical Colleges estimates that by 2034, the United States will face a shortage of at least 37,000 physicians. Worse yet, provisions in the big, beautiful bill now being considered by the Senate would limit federal loans for medical school to $150,000, eliminate a federal graduate loan program, and put limits on loan forgiveness. Because medical students rely heavily on federal loans, doctors' associations, medical schools, and student advocates are warning that if this provision passes, the anticipated doctor shortage will be even worse than currently projected. The Concerned Citizens Program Committee, believing the doctor shortage is already here, asked the Orange County Medical Association to provide us with someone who could explain to our members the causes and consequences of this development. The association offered us their secretary-treasurer, Dr. Connie Bartlett. A pediatrician with over 30 years experience, she is currently Chief Medical Officer for National Healthcare and Housing Advocates, a consulting firm dedicated to improving the lives of vulnerable populations. And she has put together a great talk. So please join me in welcoming Connie Bartlett.
Thank you, Sue. Well, good evening, everyone, and thanks for being here. We were a little concerned with the weather. I haven't heard thunder and rain in a while, and it was a shock to my system, and we were wondering when to show up, but I'm so glad that you are here. And thank you for your invitation, Sue, for having me here as well. My name is Connie Bartlett. As Sue mentioned, I am a physician by training, a pediatrician, so therefore your tale of woes will not apply to me. I cannot help you all. However, I will argue that maybe we do share some commonalities. You know, I am an expert at diapers and mushy food and whiny children. So any of you share those kind of a characteristic, like, please come and see me. We might have more in common than you think. But otherwise, I'm here to speak about the physician shortage. I will try to make this presentation quick and efficient, so there'll be plenty of time for question and answer after the presentation. I'll be here afterward for those of you who don't have the chance to ask your questions, so hopefully you can meet me afterward. So I am fancier than Sue. I have a clicker. So therefore, I will advance these myself. So with National Healthcare and Housing Advisor, I am the Chief Medical Officer. So we provide technical support and scale nonprofit organization to provide wraparound services to help with unhoused population. It's been a rewarding journey for me, and I'm really happy to see the progress we made. And if any of you have questions about those, talk to me afterward. But today, right now we're gonna focus on the physician shortage crisis. So, as Sue mentioned during her introduction, this is not new. We anticipate this for quite a while. In 2024, there's an article came out from JAMA. They say, where are the pediatricians? That caught my eye, so I keep an eye on the statistic. And of course, the AARP bulletin in January earlier this year, you saw where are the physicians gone? And it talked about the wait time to go and see a doctor, you know, a wait time of getting to see a specialist, you know, and I know those wait time statistics. I was a physician with Providence Healthcare, and we looked at those numbers, so we know how long it takes for a new patient to get seen by the primary care doctors, 2 to 3 weeks if you're lucky. And specialists, even longer, a special mental health specialist. Psychiatrists in an open panel is almost unheard of. And the amount of time to go see a psychiatrist is 3 to 6 months. So we realize the time it takes to see physician is longer than it should. And a lot of it, there's multiple factors to that, but the shortage is one of those that we have to kind of look at today because it's here and it's going to get worse before it gets better. So I am the messenger, so please don't shoot the messenger. I'm just going to here share the news. I'm not here to change anybody's mind or tell you something you haven't heard of, I hope. All right, so here's some statistic. I am a mathematician girl by nature, so you can see me show a lot of statistic. So in 2034, 9 years from now, you're talking about 37 to 124,000 physician shortage. Primary care faces a shortage up to 48,000 physicians. That's in primary care. So primary care physicians are basically your family practice, your internist, and your pediatrician. And when you look at the specialty, psychiatry, cardiology, general surgery, that's right in line with the primary care shortage. And then, of course, you can imagine the rural area, the underserved area, this is going to be, the statistics going to get even worse. So let's get into the meat of this presentation. Let's talk about some of the cause of a physician shortage. Aging population. People are living longer, healthier life, so therefore you're going to need more care. But if you all are aging, so are we. We're aging right along with you. So nearly 40% of physicians will retire in the next decade. So this is also worsen the supply of physicians available to take care of your health needs. This is one of the issues that we thought on a national level as well. So residency is a training that physicians go to after completing medical school. So for those of you who don't know that after college, after 4 years of college, you apply for medical school. Medical school is a 4-year program. But when you're done with medical school, you're not ready to be a doctor yet. You have to go through what we call residency. Residency is a postgraduate program for physicians. For primary care, as I mentioned earlier, this is a family practice, internal medicine and pediatrics. That's a 3-year after medical school. General surgery, 6 years. Cardiology, 4 years. Psychiatrist, depends on what you want to do in psychiatry, especially 3 to 4 years. So these are basically the residency slot. It will allow you to specialize in the field that you want to practice medicine in, and also allow you to be licensed to practice medicine in the field that you choose. These slots have been capped by the federal government because the funding for the residency, so these are academic institutions. Locally in Orange County, UCI is an academic institution. You have residents there. USC is also have residents there. UC Riverside have residents there, medical school. So when you look at these residency programs, these are paid positions for interns and residents that you hear about. And the government fund these programs and they kept a cap on it. It hasn't changed in the late 1990s. So you can see when you see the increase of population as a whole and you need more physicians and you keep the cap stay fixed, how are you going to produce more doctors? And the cost. Let's talk about the cost for a second. Sue, I think, talked earlier about regarding to some of the potential cut in loans forgiveness as well as debts that carried by the residents. When you look at, I'm so sorry for my blurriness, you look at the medical school, the inpatient, the in-house tuition. So these are the people that actually live in state. So if you live in California and you go to UCI medical school, you're talking about $160,000 by the end of your residency training. This is just for tuition. We're not even talking about cost of living. If you're in outer state and you come into California and you go to medical school here, usually about $260,000 for your 4 years of medical school. This is how much it costs to train a doctor. I will tell you right now that I have family members who recently graduated from Boston University Medical School. He and his wife owe over $1 million, right? Problem. So here's a breakdown of physician growth rate. So I just told you that it's the bottleneck occur where the number of residencies are limited. I also told you that it costs a lot to train a physician, especially the in-state versus out-of-state. That's a huge discrepancy. But look what happened. What happened with the doctor selection, self-selection. So primary care, internal medicine, pediatric, and family practice, people are shifting into a higher pay residency slot, right? They figure, hey, you know, if I owe $1 million, like my cousins I just mentioned, and his wife, most likely they're going to choose a dermatology residency, a cardiology residency, an orthopedist specialty, right? Because it reimburses more, and then now they can have a chance of paying back the debts and getting a house in Orange County. So the growth rate, as you can see here, is there's only 8% increase in primary care from 2005 to 2015, but look, specialties, 48% increase in the past 10 years when people are choosing a more lucrative residency. So I really apologize, I did not see this coming. The physician burnout is another reason for the shortage as well. The top 6 reasons that you cannot see, but I can because I have better eyes, not because there's anything wrong with my PowerPoint, is bureaucracy. 60% of physician burnout. The reason is that we spend way too much time doing paperwork. Some of us describe it as secretary work, data entry. And we'll take a deep dive into that in a minute, and I'm sure you all experience if you have seen a doctor recently. The 40% is talking about, I'm so sorry, I don't know why these slides are so blurry. The too many hours in working out, 60%, 34% saying they spend more than 60 hours a week working. And then this is about losing autonomy, 22%. And then this is the big bulk of them all is the EMR, the electronic medical record. If you have seen a doctor recently in any big healthcare system, like Kaiser, like Providence Healthcare System, like UCI, for instance, Memorial Care, you're probably going to have seen a doctor with an electronic medical record, and you probably get some brief eye contact, but most of the time the doctor is typing away in the computer, looking down or looking away from you. So this is what caused the burnout too. And it's a double-edged sword. I would tell you that certain things has gotten better because of it, but there are certain things has gotten worse because of it. So I'm not saying that it's not going to go away, is my point, because it has really improved the continuity of care in terms of collecting information at our fingertips. And some of the AI that infused into these machine learning is that reminding us about life-saving lab that you do for that we didn't get to take a look at, or about your chart, about your recent ER visit, that actually it triggers some of the testing of some of the reminder at point of care. So I'm not saying it's a lost cause, but what it did do is really had degraded the relationship between your doctor and you because of the time that we spend looking for things on the internet. Just like you and your kids sitting around at the dinner table and surfing through the phone, right? Because there's very little eye contact, and it's really not good for that relationship building, and I'll show you some statistics later regarding that phenomenon as well. The other cause of physician burnout, besides the administrative burden, is I mentioned that the EHR, the dominate the physician's time. When you look at this, over 50% of the day, our work is on the EHR. Sue asked me earlier, I see a patient every 15 minutes, 4 patients in an hour, and she asked me, how do you find time to do your paperwork? Or your all the other stuff, checking labs, answering messages. How do you find time to do that? You do it on your own time after work. So in our world, when I was in practice, we use Epic, is an electronic medical record. One of the things that we measure to make sure that our patient is getting the throughput, but also physician is using the system efficiently, we call it pajamas time. So we measure the time that the doctors log in and work on the EMR after 5 p.m. until midnight, and then from midnight till 7 o'clock in the morning, and we measure these time. Not to be nosy, but we want to know who needs the extra help in their electronic record documentation so we can help them improve their efficiency and get through the throughput. But you'd be amazed how long. I have doctors who, because you can see the digital timestamp when they log in and document, 2 in the morning. 3 in the morning, 5 in the morning that they're up and they're just doing the chart and trying to calculate because they know the next morning there's 16 patients waiting for them and there's no way they can catch up during the normal office hours. So as you can see, this is a huge impact in the physician's day-to-day life. So as if that's not bad enough, we talk about the 60 hours plus a week. I have not met any doctors who work 40 hours a week. The interesting phenomenon, and when I was at the medical group, is when we start interviewing younger doctors, they don't want this. The day that physicians come out, hang their shingle, and work hundreds of hours a week to build a practice and their reputation and build that gone. This newer generation doctors, they don't want to work long hours. What they ask for is not, I would say, okay, what if I pay you more? It's not important to them. They want balance. They want work-life balance, real important to them. They want time off to go, work in the free clinic in Southeast Asia. They want time off to go hiking with their family once a year. They want time off to do other environmental causes. So it's a very different population of physicians coming out, and this is not going to fly. They won't come and work for 60 hours plus a week with full of bureaucracy, high patient load, and this kind of lifestyle do not attract the new physician coming out. And it's kind of interesting because I'm at the age when a lot of my partners looking like you guys, very mature and very, very handsome. And they say to me, they go, Connie, what is wrong with this generation? Why they don't want to work like we do? We used to walk up the hill both ways, barefoot in the snow, and we never complain. But you know what? I said to my partners, I said, I wonder if they got it right. Isn't work-life balance is important to them, and the mental health, the well-being, and whatnot. So it's kind of interesting to see that dynamic where I can see both sides of the coin. I'm like, yeah, you want them to be hard work, but you don't want them to work themselves to death either. So here's another fun fact, autonomy. A lot of physicians start losing their autonomy in terms of who's making the shot nowadays. You think we're calling the shot? No, it's the insurance company, it's the health system, it's the CEO of the corporation, and now we're facing with private equity acquisition. I don't know if you have heard that term, private equity acquisition? Yeah? So this is kind of interesting. So these individuals it's a pool of investors. They pull their money together and they target these practices with potential growth or operational efficiency. They would acquire these practices, especially this private medical practice, and they will completely do a reorganization, improve the efficiency, the throughput, profitability, and after a certain amount of time, usually 3 to 5, 5 to 7 years, they sell for a profit. That's what private equity is doing, and they are just going after these private practices. So this sounds really kind of cynical. However, if you are a practicing physician, you build a successful practice, and now you see your practice degradation in terms of the bureaucracy, the time you spent in the EMR that you can't afford, seeing the number of patients that are unrealistic. And then somebody comes in and say, I will pay you top dollar for your practice. You don't have to worry about this business bureaucracy anymore. I will take that over. All you do is just practice medicine. You get to do what you really enter medicine for. That's a pretty good proposition. So I don't blame these doctors to say, you know what, now I don't have to worry about the business part of it. I can just practice medicine and do what I love to do and what I do really good at. Why not? But this is a problem. This is about the profitability of medicine, corporatization of medicine, and it's not good for the patient. So when they sell these practices and they go through this reorg, it's all about the volume and profitability, and sometimes at a cost. And you paying for that cost. There was a study done by Harvard a couple years ago, and they showed it compare the way that the equity-owned firm practices versus a private equity-owned practice. And they show that in these, they look at the hospital who owned by private equity versus the one who are not owned by private equity. And the study actually showed that as far as mortality, actually improved slightly. However, medical error increased significant, quality has actually gone down. Because what happened is in order to improve profitability, you got to have more bodies in, and the quality goes down because the nursing staff can't keep up. And also cost cut, right? They may be switching out a certain widget that's going to be cheaper than the other widget, especially if you do a high volume surgical procedure. These cost cutting will have consequences. And you do see some of that in terms of quality. But otherwise, it's a great profit for the investors. But medicine is not about investors. Medicine is about human life, and we don't look at it in that term. So here is some of the private equity firm, just in case you have to go, who are they, and how do I know how? And this is a gastro. GI is a very high procedure specialty. So as I say, when private equity looking for a practice to obtain and to acquire, they're usually looking for high profit, high margin practice. So you're not going to see a pediatric practice in here, but you will see mostly a procedure-driven specialty, orthopedics, ophthalmology, GI specialist. And then, so besides private equity, talking about acquiring all these private practices and going for the bottom line, making a margin and trying to sell for profit, this is the other issues that we run into, prescription advertisement. I mean, I'm sure we all have seen those commercials on TV about new drugs. This is going to make your skin completely normal. It's going to make you lose 20 pounds and looking like a supermodel and whatnot. This comes at a cost as well. What it does, it advertises you and gives you a false hope for a cure. And then, of course, at every commercial, it always is disclaimer, go talk to your doctor. And your doctor will prescribe it. And then what happens, people will come to my practice and say, hey, I saw this antibiotic prescription, or I saw this medication for eczema, or whatever it is, I want it. And then what happened? The insurance deny it. And they call the insurance company and go, oh, if your doctor says okay, then we are absolutely going to approve it. It doesn't work like that. That's false. I'm not sure it ever happened to you. We don't have any control of the utilization of some of the drugs that the insurance have their own, what we could, a dictionary of a certain drug that they approve. And if it's not on that list, they won't approve it. So some of these drugs, when it tells you that, yeah, it worked really well, and the other thing it doesn't tell you, it doesn't look at you individually as a patient. What are the risk factors that you have that may not work best for you? Some of these medications may have far more side effect than benefit. And how do I know that? So when you look at the two countries that allow drug commercials on TV, us and New Zealand, and look at that, US, New Zealand, the only two countries where citizens take more than 2 prescriptions daily. They've got to have some cause and effect in terms like that. How many of you at home sitting around mind your own business after a wonderful dinner, and then it's 9 p.m. and this really amazing commercial is telling you that, yes, you want the 4th meal. Go to Taco Bell right now and grab that taco. I would bet you, not all of you in the room, but some of you go, that taco looks really good. Maybe I do need a 4th meal. It does have an impact in your psyche. And look at the benefit of it. 71% of this TV ad spending have low benefit medications. They got the funding, but the medication doesn't really work. Only about 29% of those commercials. And you as a consumer, how do you know which one is the 71% and which one's in the 29%? So the parasite prescription, this is a Johns Hopkins article that came out last year. It's just kind of warning you about the consumer advertising. And the majority of the top 1 to 2/3 have a low added benefit compared to other drugs. So there's really no, but just because it's an ad, it doesn't mean that it'll work for you. And this is another impact to our day-to-day life in medicine, WebMD. I love WebMD and then I hate WebMD. I will tell you the truth, won't lie. You know how many times parents bring to me WebMD parents, I call them articles, like 2-3 inches thick about a new therapy. As a pediatrician, and please no offense to anybody, vaccines controversy, right? Whether or not they should and should not receive vaccines. There's a lot of information on vaccines on the internet, but there's also a lot of misinformation about vaccines on the internet. And I can say to other medication as well. And WebMD is a great source, but you have to look at WebMD through a grain of salt. There's a lot of information on the WebMD. And for us, that's why we spent 4 years of medical school and 3 to 12 years of residency afterward to learn how to decipher this information, categorize it, and make a differential diagnosis, and come to your diagnosis that just fit you individually. So I hope that you will not trust WebMD over your doctor's recommendation, but I have to sit and spend 20 minutes that I don't have, explain to them why the WebMD is false, and your child does not have lymphoma or leukemia. Oh, my kid has a bruise. It hasn't gone away for 2 weeks. And he was laying around the other day, and he's not eating very well because no parents ever tell me the kids eat well. He must have leukemia. Do some blood work. And how about bone marrow? Really? Yes, bone marrow. You'll be amazed. Parents will volunteer the kids for bone marrow just to prove that he doesn't have leukemia. Here's another one. Okay, I will tell you the truth. I love this, but then I also hate it. Yelp MD, right? So how many of you nobody go to a restaurant without looking at Yelp, right? Nowadays you gotta look at Yelp first and kind of read through it. And like me, you're gonna read through it and you're gonna go, okay, this one is junk. Okay, this sounds like a good restaurant. They just complain about the waitress attitude, but the food looks really good. But you have to use those kind of lens to look through these Yelp review. So we have patient satisfaction, physician satisfaction. I don't know if you ever received one after you go and see your doctor in the email, text messages, paper, like patient survey. This really matters. The positive aspect is it really does improve care. We look at patient satisfaction at the medical group and we publicize it. So I have 100 doctors in the St. Joseph division of my medical group. And you will see from 1 to 100, name and the patient sat number right next to their name. If you look at any of Doctor in Providence, you see the patient satisfaction attached to their profile on the internet. We publicize this. We want you to know. And it does help to improve the patient care a little bit in terms of patient-centric. We want to make sure that you are being addressed the way your healthcare ought to be, not how we think your healthcare ought to be. And this helps to drive some of that behavior. So we do have those in the bottom quartile. We do offer them, a peer-to-peer counseling. They shadow a doctor a high performer. We try to help them to make sure that they improve their patient SAT score, and it does work. But like everything else, it lies. So when you look at these patient satisfaction number from physician, you probably see the same guy in the top quartile and same as some people on the bottom quartile. But it does drive behavior, especially the one in the middle that we want to flip. But here's a negative impact of patient satisfaction, right? So sometimes it looks for likability, popularity contest, rather than good doctor. So we have doctors who are very well likable, but they prescribe anything you want. I know this is you're only 2 days into your amoxicillin, you want augmented instead? Absolutely. How many Vicodin you want? Unlimited. Yet that's not good medicine either. Pressure to make high score and a necessary prescription. We do have doctor shopping patients who go from doctor to doctor because they know exactly who's going to prescribe. I have patients who come to me and I would explain to them, this is a viral infection, you don't really need antibiotic. And they say, but Dr. Joe said I can have it, and he gave it to me every time I get a cold. I'm like, okay, go to Dr. Joe. And then, of course, I get a ding for that. Dr. Bartlett was being difficult to me today, and I don't like it. She did not prescribe life-saving antibiotic for my cold. Financial incentive. So yes, we do put financial incentive in patient satisfaction. That's the only thing we do as an individual incentive. We try to drive some of that incentive. We drive some of the behavior changes, but that incentive is so minuscule compared to other meaningful like colonoscopy, mammography, other life-saving measure. But we do try to incentivize some of that. But is that a good or bad thing? According to this, it's actually not a good thing. But we do put that into our compensation model. And I have physician, as I mentioned, in the bottom quartile. So we try to improve. Remember, we publish this. So all of my physicians know exactly where they are in that scale. And yeah, it stresses them out a little. You know, you can imagine if you're consistently in that bottom quartile, no matter what we do, you only bump by 1 or 2 points, and then you never got through that 50th percentile or in a higher quartile. It can, as you can imagine, it can add stress to your life. So it's a love and hate thing. I think it's necessary, is there because it really unveils things that we need to improve. But at the same time, you know, it's like everything else. You don't want to rely too much on it. This is the doctor who says it's time to administer the patient satisfaction. She's all relaxed with a cucumber in her eye, face mask, and a drink. Okay. So so now that I went through some of the issues with the burnout, the bottleneck, the cost of training, as well as some of the undue stress to our life, let's look at some of the solutions to address the shortage. How about increase that cap number, right? That's simple. Expand the medical seats and scholarship that Sue just said that they're cutting them. Incentivize primary care and underserved area practice. This happens today. I will tell you right now, it happens right now. However, we have these doctors that sign up for these loan forgiveness area and underserved area for 3 to 5 years, and then they leave the area after loan payback. So it's really hard to anchor them because some of these areas, can you imagine, if they don't have family or any reason to be there, they'll go there and then they'll leave afterward. Otherwise, how about reimbursement model changes, right? Utilization of care and technology, the use of NPs and PAs. So these are, we call APCs, advanced practitioner, clinician, and it has expanded their scope of practice in recent years. I don't know if you have seen a physician lately, but if you're a relatively healthy patient, most likely you're going to see a NP or PA when you go into an office or a large practice, mode practice. And then you will see a doctor if you have complex medical problems. Otherwise, you just see a mid-level or advanced practitioner. So we are utilizing more NP and PAs, and they are cranking out as fast as they can. They're really good. They're really good clinicians, and now NPs can practice in California without physician supervision. So you can see more and more of them. They can prescribe. They can, treat you just exactly as a primary care physician, similar to primary care physician. And then the increase the use of telemedicine and AI-driven diagnostic. This is going to be a huge revolution into the healthcare in the next 10 years. Telemedicine is here to stay. I don't know if you ever, this is the first time you ever use it. I think the COVID pandemic accelerate the telemedicine. It was kind of been there in the background. Interesting thing is that 2 years before the pandemic, I'm one of those physicians when I was in practice, I'm an early adopter. If there's a technology that's gonna make me more efficient, improve my doctor's lifestyle, make it better for them, I will pilot and I will test it and I will let everyone know if the pilot work or not. Telemedicine was one of those that I pilot in my practice. 6% was the adoption rate pre-COVID. Pandemic happened, overnight, 75% adoption, overnight. It takes a pandemic to find sugar, but it does. But this is here to stay. I don't know if you ever used telemedicine in the past or recently. It's a pretty cool tool. Now, there's nothing can replace the physical visit, right? Look in your ear, listen to your heart, touch your skin, look at things. I mean, there are things that cannot be replaced. However, for a simple cough and cold, something that we can just diagnose over the phone, this is really convenient. And one thing in the pediatric practice for me, I call this it gives me a more holistic view of my patient. I had a kid who has asthma for 12 years. I couldn't figure out why medication's not working. I am an asthma queen. I would tell you that there's nobody in asthma in my practice that I cannot fix except this one kid. And then the pandemic happened. I did a televisit. There were boxes and boxes in his whole house. It covered boxes, and there are like a dozen cats walking around in the background. I just cured his asthma. I just found out why. So without telemedicine, I'm not gonna go to his house. And when they come to mine, no one mentioned about the cat. I don't see any fur on him. I didn't know that there were boxes and boxes of things in the house. So I think telemedicine allow us to enter a patient's house, and we really get to see a lot of things that we would have missed when we can't follow them home, right? And then AI, I would tell you AI in radiology diagnostics tool is going to be amazing. I think AI has so much promise. They pick up things, subtlety, that radiologists missed. So I think in radiology field, this is going to be tremendous in terms of AI technology in some of the fields that are more objective, looking for those that spot or like lesion that millimeters in size. So it's more to come, but I think this is interesting. But like everything else, it's really, they're meant to be an enhancement. It will never replace our brain and how we work and how we correlate information together that really help to form an information about a patient. AI can't do this. Administrative burden, so we talk about optimizing EHR. So nowadays, if you ever gone to a doctor that has Epic, Ambient is a dictation system that use AI technology. So what happened is I click on my phone, hit record, and I will have a conversation with you. We would talk about your vacation, about your cat, about your favorite meal and whatnot, and then we got into that swollen ankle that you came to see me for. By the end of the visit, I am now having face-to-face contact with you the whole time. We're talking about everything you want to talk to. It only captured the swollen ankle, and it learned how to delete all the other non-important information now. That's how good technology has become. Streamline the prior authorization. We're fighting like heck right now in Sacramento. And actually the bill got to the governor's desk and got rejected because of the cost behind this. So what we're trying to tell the system or the policymaker is that if I am one of those doctors, that 99% of my authorization has been approved in the past 5 years in practice, that shows I'm a good doctor. I'm a good documentation. I use it correctly and I know how to do it, then I should get a fast pass. So every time people like me, I should have go through prior automatic go through. And in 2 years, you can check my pattern referral and let me know if I still deserve that gold star or not, that fast pass or not. So this is going to be coming, and I think that's going to help you, especially if you're in the HMO system, when you sit around waiting for that authorization for your MRI, your CT scan, your ultrasound. This will eliminate that unnecessary wait time. Team-based care. I don't know any of you participate in team-based care in your practice. So team-based care means instead go see a physician on a one-on-one and then you go make another appointment to go see your pharmacist, or you go somewhere else to go see your physical therapist, and you go somewhere else. Team-based care is a group of clinicians. When you go in, your visit is about 1 hour long. You will see a clinician, a nurse, a pharmacist, a social worker, case manager, to help navigate the system if you have a complex healthcare system, the diagnosis. So this, you can see more and more team-based care is pretty good system for us to put in place to help manage the larger population. We can see more patients in one day, and then the patient themselves get a lot of value in team-based care because all of their healthcare needs are being addressed, besides not just the physical, but also the mental health and psychosocial needs. So our complex senior members in our medical group, this has been a tremendous patient satisfier as well as a clinician. Protected time for rest and flexible schedules, of course. And then mental health support and wellness. We have more and more physician wellness initiative in each medical group. So this is how we address burnout in terms of provide peer-to-peer support, as well as we do spa day, we do walking rounds, we do activities that encourage doctors to go outside and just be among their peers and take better care of themselves. So a lot of these mental health as well as emotional, and we also have confidential mental health support in our medical group where they will receive free and confidential evaluation by the therapist if they are under stress or they're going through a bad divorce or lawsuits, right? That's also another big stress to the doctors. What seems to be a problem? I feel the way you look. And then restoring the physician autonomy. This is really important. Transparency about the private equity. This is something that we don't know unless you go dig. You're not going to know if your doctor practice has been acquired by a private equity. Non-compete clause. So when I leave the medical group, there is a non-compete clause that I cannot practice within a certain radius in a certain amount of years. So this is one of those things that can hinder a physician's ability to move around and change practice. Physician-owned practices. This is a dying breed. I was talking to Sue earlier on the way over here. It's really hard to find physicians that want to go out and hang a shingle and do their own practice. You see more and more new physicians coming out now. They will join medical group or hospital-owned entities just because of this. It's really hard to can afford to put the business together, especially with the EMR system and the cost of hiring your nurse practitioner, your office manager, and all the utilities and all the cost of leasing a building is unattainable to a lot of these young doctors with $1 million in debt. Collective bargaining. And this is one of those things that we talked about. We don't have really medical students, you can, but physician cannot unionize in the state of California. However, we do have this, and this is how, this is the organization I belong to, the Orange County Medical Association, where we are banding together and we lobby for policy changes in Sacramento, as well as in Washington, D.C., when you go up to the AMA level. And we're talking about, things that are important to our practice, whether it's a practice modes, reimbursement models, our autonomy, physician-patient relationship, economic stability, technologies. I belong to the CMA, California Medical Association, IT Health Committee. So right now we're looking at some guardrails to put around AI to make sure that when we use it, number one is transparent, so we're using it. And then we also have to put guardrail around where that information go, right? HIPAA is huge for us in medicine. We live and breathe HIPAA. How that information can be protected and not being all over the place randomly. So there's no one way to fix this. It's a multifaceted way to require addressing the burnout. We talk about physician wellness. We talk about workforce distribution. Financial barriers is a key. So we talk about some of the reimbursement model changes. We also talked about some of the workforce distribution by the employment of the APC, advanced practitioner. Policymakers must work together. So we're doing just that through the OCMA and the CMA and the AMA, where we are all hand in hand with the policymakers to make sure that we preserve some of the autonomy and make sure the healthcare is sustainable for the future physicians as well, the current in practice doctors. And then, advocacy is huge for us. Policy change, invest in future medical professionals. So, your book sales, I have a great foundation you want to donate to. Just kidding. But there's a lot of things that are being done on the and then because this is a problem that's not going away, and there's no one size fit all solution to this. But yeah, we're actively working every single day to make sure we address the shortage because it's here to come. And we also talk about importing physician outside. So we're trying to loosen up the rules for the foreign graduate. There's a lot of hoops that they have to go through to be licensed to practice in the United States, especially your foreign trained physicians. So we're talking about some of the ways that we can shorten the training and loosen up some of the barriers for those physicians to get licensed in the United States to practice. So there's a lot of work to fix this. And that's all I have. Thank you very much.
Thank you so much for a very clearing, insights, presentation. I noticed that there were two statements. When I grew up 100 years ago, the best students were in math or science or went to medical school. And 10 years later, they went into practice. today, the best math and science students go into computer science, many of them without a graduate degree, some of them getting a $250,000 as soon as they get out of college. And I'm wondering if you could comment on that. The other thing was, and begin just a personal reference, my granddaughter getting out of college spent 3 years doing Teach for America in underserved communities, was paid as a teacher after minimum amount training. Is there anything similar in medicine where young physicians could be paid to go to underserved communities? That's my two.
Perfect. Thank you. So yes, we do have loan forgiveness and also a scholarship for a physician who wants to practice in the underserved area currently right now in that system. And your question regarding to the brightest student going to math and science, and now you see more and more of those going to more lucrative and less lengthy training process, right? As I mentioned, it takes 4 years of med school and 3 to 12 years, depending on what specialty you're going to become a physician, and the mounting of debts. If I am the 1% student and I can get a job at Google right out of college, not even you don't have to get a graduate degree, and make a 6-figure income, that might be a draw for me. However, as I say, medical school application we haven't seen a decline in medical school application in recent years. So people still enter the medical profession, I would say mostly for the right reason. This is a calling. I don't think there's enough money to put you through all the pain and suffering of getting into medical school and going through the residency and all the sacrifice that you have to do to become a physician. It is a calling, and I think that people still entering mostly for the right reasons. So we still attract the brightest, the best. But I do see the shift, like my family members, for instance. I do see a lot of my niece and nephews when they come out and look at I have a niece right now who's a second year in medical school at University of Florida, and they look at her and they go, you know what, I'm going to go to UCI, get my computer science and do an internship at Google. And then when I leave, when poor Sabrina is still sleeping away, 100 hours in the hospital for minimum wage, I'm already making 6-figure driving around in my Maserati. There is some draw to it, but as I said, I haven't seen the drop in applicants, so that still gives me hope. And the people who are entering medicine, the criteria has not changed in terms of the MCAT score and the requirement, the GPA to get into med school. So there's still we still attract the brightest, and hopefully because of what you just mentioned, I'm hope that will kind of filter out the one who wants to do for the money and the glory, because this is not where you want to go into money and glory, not medicine. And then hopefully we will attract the right people, the brightest, the smartest, but also the right people who go in for the right reason. Yes, ma'am.
I just wondered if countries that have single-payer systems like Canada and Britain have the same issue of value physicians in the future as we do.
So the last time I looked at their statistic, it's like they have some but not as severe. But again, I think that throughput is different than ours in terms of, I'll give you an example. My brother-in-law is Canadian. He came and visited, and his kid broke his leg before goofing around. I got him an orthopedist appointment the day after, and he was shocked. He go, in our country, that would be a 3 months wait. I said, 3 months? That thing's already healed crooked by then. And then I was telling Sue in the way, and then the other thing is when he came out, I don't know if you've seen anyone with a broken arm, fiberglass is what we use. Fiberglass is like one of those things you wet it and you put it onto your arm, it shapes your arm, it has all these cool colors, and some of them are waterproof. He almost fell over. He said, I've never seen that, because in Canada, in this day and age, they still use plaster. The powder thing that flying all over the place. So there is, in terms of wait time, in terms of availability, in terms of technology, I think there's a cost to that. But the flip side of the coin is then everybody get health care, right? It's not going to be like ours where the have and have not. And what happened is the have pay for the have not. Yes, ma'am.
Yes, hi. Forgive me, but I'm on a warpath. But what's happened to medicine now, technology and science has gone way up, and patient care, unfortunately, has gone way down. And personally, my experience has been that the cause of a good percentage of doctors not becoming doctors is because of the financial people that are changing the way in which hospitals run and those that are buying up private practices. And that's the cause of all the paperwork and all the non-government a little bit, but it's mostly these people who sit up there in the ivory tower and do not look at people. All they look at is a bottom line. And aside from that, I would like to know what you and your group is lobbying for.
You mean from the OCMA?
Yeah.
Because we have about 60 things that we're working on right now, but off mine recently, the prior authorization is a huge one because that's really put a burden in the relationship between the physician and the patient, especially delayed care is a bad idea. I would tell you a story that I fought with a health plan for a nebulizer. Remember I was telling you I'm an asthma queen? They refused a nebulizer that you could buy online for $50 or something. Refused a nebulizer, the kid ended up in the ER and got admitted for a week in the hospital because he didn't have a nebulizer. He was too young to use an inhaler, so he needs one of those machines that spit out the aerosolizer medication on the mask. But that makes no sense to me because why would you deny a $50 nebulizer but you pay for 1 week worth of hospitalization?
Because they don't allow doctors to be doctors anymore.
Right. And sometimes, and that's why, it's so important that we have to band together and we have to lobby the people who make these policies and make it, basically tie our hands behind our back. It makes practice medicine really difficult, and sometimes it doesn't lead to better care. If anything, it makes care worse.
I wonder if you could just touch for a minute on what's happening with the hospitals themselves selling medical insurance. In other words, the person that collects the money is setting up the program for how much that we get.
Yeah, so the perfect example of that is Kaiser, where their own health plan as well as their own hospital and their own medical group. So if it's like everything else, when it's done well, it works really well. But you're right though. Sometimes because
I believe Providence is the first one for stuff.
Yes, and Providence does have their own health insurance. It doesn't do. I think in other states, I think in Seattle, it works much better in Washington, but not in California. That's not something that has taken off since I've been there. Yeah.
Right. Yeah.
Okay.
Yes, ma'am.
Couple questions for you. Thank you for your presentation tonight. You talked about the electronic medical records, and I read the article that you referenced in AARP, and that was the first time I was aware that is something that is required by legislation, correct?
Not required because I know 30% of our independent physician practice in the Orange County area that's still on paper.
Okay.
Yeah. However, what you're talking about is some health plans. In order for you to participate in their incentive program, there has to be a way to collect the data. So EMR will require if certain health plan, if you're going to participate in certain incentive program, but it's not a requirement for physician practice to have electronic medical record because there's still a lot that's still on paper.
And you said in your talk there was something that how do you evaluate it? Are you evaluated on your EMR? On your EMR records? I kind of picked up something.
No, we don't get evaluated, but we do track EMR use. In terms of, so, and not an evaluation, well, we don't give a doctor, you're an A user versus a B user, a C user. Okay. It's not like that, but most of the time, because there's so many ways for you to slice and dice the EMR, we call it customization to the way that your process work. And what we do is, the reason we track some of these doctors for pajamas time, we call it, when the after hours use, is not meant to be punitive. It's just meant to help them improve their efficiency. Yeah.
And going on to about the doctors and supporting them in their mental health.
Yes.
Okay.
Yeah.
how often really do doctors use that service?
We're the worst patient you can imagine. Oh my gosh, we're the worst. That we
Can you say like 20% of us do, and 50%?
less than 10%.
Less than
Yeah, yeah.
Okay. So yeah,
We doctors take care of thyself. It doesn't work in medicine. You know that. I mean, we have doctors that I say, I know you have a mental health problem because nobody in the same hour will ever do something that you just did. But like encourage the doctors to seek help.
it's good to know that it's available for them.
Yes.
But I was curious about percentage. Another question is, and I've heard this come up in conversations with friends and family, is that look at all the debt that these doctors have when they come out, but their sufferings are going to cover it.
Yeah.
Is that true? And how long does it take to pay down debt?
Well, it depends on individual doctors, right? As far as that spending habit, they come out residency, they owe $1 million, but then they have a 6-figure income, right?
Okay.
Well, are you disciplined enough to put 40% of your income range, pay off your debt, or you want that fancy house and boat and vacation, and then you pay your debt out? Well, usually the average about 20 years. It's like a mortgage.
Okay, that's a number I can share with others. Okay, my last question.
Yeah.
My last question is MCAT. How many students actually pass that on the first try?
You will pass it, but the MCAT is not pass or fail. The MCAT is a score. Okay. That you score in the upper percentile, and then the MCAT also coupled with your GPA too. Okay. So MCAT is just like an SAT. Okay. It's a standardized test, so it's not like you pass or fail it, but of course you want to be in the upper quartile with a 4.0 GPA, and then your chance of getting into a more favorable school then it's much higher than if you get the lower. Yeah, so it's MCAT. Think of MCAT as like a SAT standardized exam for college entrance, but this is for medical school, and then LSAT is the same. Yeah, for law school. Uh-huh.
Okay. Thank you for answering all my questions.
Of course. Yes, ma'am.
My primary care physician is going to become a concierge doctor.
Yes.
And if I don't agree to do it, I am told it's going to take a lot more time to get to see her and to get care. What do you have to say about that?
So concierge medicine, a lot of physicians are moving toward that to reduce the burden of the panel of the patient. So your doctors must have a hybrid model, that he giving you a choice. If you want to pay this monthly fee, you get to be in front of the line. This is the Disneyland fast track behavior, right? Or the TSA pre-check. If you don't want to pay the concierge fee, you can be in the rest of the patients, and then your access to your doctor will be a little bit longer. But that's still your doctor. So if this is a doctor you love and have a long history with, then you can either pay the fee if it's reasonable to be a concierge practitioner to be in that pool, or you can stay in the regular pool. I'm seeing there's a lot more movement of physicians who are basically, before they turn themselves in, like quit medicine, they convert into concierge practice as a way for them to cope. Because nowadays, for a primary care physician, you need to have a panel of 1,200 to 1,500 patients that you care for. Concierge, 500 patients. But in order for me to manage a panel of 500 patients only, I need to supplement that with your fees to make it worthwhile. But then you get my cell phone number, you get to get the same day appointment, you get me a back and call.
$1,000 a month, is that common?
Yes. Yeah. $1,000 a month is common.